It is now my utter pleasure and honor to move us on to the topic of the evening, which is sexual health in gender-affirming healthcare, and a person that I regard as a role model, a powerhouse, as a South African woman and professional who has done such groundbreaking work in the field of sexual health and sexology, not only in South Africa, not only in the continent, but around the globe now. It is my pleasure to introduce our speaker this evening, Dr. Elna Rudolph. She's given me a very brief and a very modest bio, which I will stick to as best I can. So Dr. Elna Rudolph is a medical doctor and a sexologist in South Africa. She is the clinical head of My Sexual Health, a multidisciplinary group of credible sexual health providers. They offer gender-affirming care to hundreds of trans and gender non-binary folk in the context of a multidisciplinary team. She currently also serves as the president of the World Association for Sexual Health, often referred to as WAS, and a lecturer in sexuality for the WPATH GEI Foundation course. Welcome, Elna. Welcome to the PATHSA space specifically tonight. We are really looking forward to your presentation, the journey along the topic of sexual health in gender-affirming healthcare. I hand over to you.
Thank you, Ron. I appreciate it. I have to be honest, I don't think I've ever had as much imposter syndrome as I have here tonight. I don't know if you guys realize, but I feel the gravitas of really being in the midst of greatness here today. I know that so many of you know so much more about this topic than I do, so I feel honored to be asked to speak here, and I apologize in advance if anything that I say sounds patronizing or way too basic. And I am also, I took out my notebook here because already as you guys were talking, I was updating my talk because I'm also firstly, foremostly here to learn. And it's a privilege to be here. Thank you for asking me. And I mean, I also, anyway, language is everything. So let me share my screen and get started before I get into too much of talking nonsense. So there we go. So disclosures in terms of pharma, and that is that obviously no pharma is involved at all in anything that we do here tonight. And also then something that I have to be very clear about is I've recently read Lucy Fielding's book, Trans Sex. If you haven't, just do it. Really, you can, in fact, stop this talk right now and just go and buy the book, and that would be sufficient, I guess. It is a fascinating book, and she is just such a well-rounded clinician and individual, and it was really a very enriching read for me. I wish I had 1% of the eloquence that she has to convey the message that she does in this book. I mean, the talk isn't wholly based on her book, but of course, having read it recently, she influenced my thinking about it, on top of all of the other influences that it's come through the years. And then everything at My Sexual Health is based on these phenomenal guidelines done by these people. And those of you who are on the list here, I just want to thank you again for spending the time to come up with these phenomenal guidelines, because now a patient can take this to their local GP and be treated. And that's just amazing, because offering gender-affirming care as a clinician, as a healthcare provider, as a medical doctor, is actually not that difficult. And it is possible for anybody to start. And if you run into trouble, then of course you can refer to a more experienced team or centers. So this has been an absolute game changer for trans patients. And I know the uptake is slow. I mean, I started a sexual health clinic 10 years ago and thought that I'm going to have a clinic in every suburb within a year. And it doesn't work like that. There is slow uptake, but still it needs to start somewhere. So again, I want to congratulate you and thank you for your hard work to put something as phenomenal as this together. So this is my location of self. I'm a cis, het, vanilla, monogamous, white, crazy privileged, Christian, ethical, science-based and experience-informed medical doctor, and I probably should have put there sexologist, which is what brings me here tonight, volunteer president of the World Association for Sexual Health. So I feel that, you know, that immense power and influence one has in that position should also be counted with the fact that it is a volunteer position and that it is something that I do out of passion. And yes, you know, I mean, obviously my pathological ambition plays a role in me getting there, and a lot of grace and luck and I don't know what else it is, but it's a volunteer position because I'm deeply passionate about sexual health. And trans and gender diverse people's sexual health is really one of my greatest passions. And I didn't start there. You can imagine that this girl was raised to believe that anything other than cis, het, vanilla, monogamous sex is sin, and that there is absolutely no space for it. And even after I had a master's degree in sexual health, I still couldn't really go beyond that. So it took years of training and I don't know what, you know, reading and being exposed to the right people, and just I had to, it wasn't easy for me to change. I was way too religious to treat trans people in the first few years as a sexual health provider. I just didn't feel comfortable with it until one day I realized how unbelievably, what's the right word now? I'm just such a fake and so self-righteous that I think I can have a boob job because I'm not happy with the body that God supposedly gave me, and I can put plastics in my boobs, but I can't help another person do something to their body that makes them feel more comfortable. So I just realized that that's absolute nonsense, and that for me as a clinician, gender-affirming care is very much involved in that process of bringing hormones and bodies in line with who a person really is. But and then obviously it's much more than that also. But yeah, so you know, I just put that out there because my journey coming here wasn't an easy one, and or it is not something that I take for granted, and therefore my position as a lifelong student, and to be in the presence of you guys who've, well, many have lived experiences and others as clinicians have so much experience with talking with patients over years, and then the learning that you have done as individuals as well. I really value that because it didn't just fall from a tree for me to be here today. So just to put some definitions on the table, we use trans and gender diverse people or children. That TGD is a very common what's the word, abbreviation that we use, also at the World Association for Sexual Health. But in Lucy Fielding's book, she talks about trans and non-binary folk. And I like that, you know, that X coming through often in the queer language, and it's an emerging term. So I did throw it in here a little bit, and I would like to hear from trans and non-binary folk on this call later, whether that sits well with you or not. And then gender affirming care, we prefer gender affirming care rather than gender affirmation care at My Sexual Health, because a person starts with their gender affirmation, but then live in their gender affirmed bodies for decades. And the medical doctors and psychosocial team are there to continue to take care of them. A lot of emphasis in the literature, at conferences, everywhere we speak, is on diagnosis, on how do you start treatment, how do you initiate, how do you, and surgical changes and things around the time that the gender affirmation process starts. But then, you know, I have known some trans people for many years, and their hormones are absolutely perfectly stable. And that's then where I get into a position where I can really spend time with the person, and where the opportunity for me to possibly act as a sexologist then arises, because trans and gender diverse people that see me do not see me primarily as a sexologist. They see me as a person who offers sexual health services, one of which is gender affirming care. But at heart, I remain a sexologist and very open to speak to people about their sex lives. But it doesn't mean that many trans and gender diverse people actually speak to me about their sex lives. It's their choice whether they do so or not. And it typically only happens after we've done the settling of the transition, and then you know, those kind of questions come up as they know and trust me more. And I'm sure those of you who work in a practice experience the same thing. So if you look at the definition of sexual health, this is the WHO definition, and was very, very much involved in putting together this definition, is the sexual health is an integral part of overall health, well-being, and quality of life. It is a state of physical, emotional, mental, and social well-being in relation to sexuality, and not merely the absence of disease or dysfunction or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all people must be respected, protected, and fulfilled. So then I just went and rewrote this a little bit so that we can really make it applicable to our trans and gender diverse clients. So it could potentially read like this, and it's something that I would love some comments on, to see that, you know, I, as a non-trans or gender diverse person, put these words to it now, but I would love to hear from you guys to see that we maybe, you know, maybe at WAS we can officially do a statement like this. So it says, sexual health is an integral part of overall health, well-being, and quality of life for trans and non-binary people. So it's not, here are your hormones, there's your genitalia, whether they fit or don't fit, and then sexuality is somewhere there. How you have sex, when you have sex, with whom you have sex, is this tiny little part that people are very curious about and fetishize. Somehow I read that earlier easier than I say it. So much there's so much unwelcome interest in the sexuality of trans and gender diverse people, but their sexual health is an integral part of their overall health and well-being and quality of life. And it is a state of physical, emotional, mental, and social well-being in relation to sexuality, not merely the absence of disease, dysfunction, infirmity, gender dysphoria, and body parts that do not fit. Because when we start seeing patients, the gender dysphoria is so prominent, and as healthcare providers, we are often very involved with and concerned with, and the public and the media is concerned with these body parts that don't fit. And obviously for the person living with it, it can be all consuming, and it can be completely prohibitive to do that sexual embodiment and be comfortable with themselves as a sexual being, never mind the world's inability to see them just as a normal sexual being. Sexual health requires a positive and respectful approach to sexuality and sexual relationships by the trans and gender diverse person themselves. I often make a mistake with that. I said TGV and instead of TGD there, but by the person themselves. They have to respect themselves and see themselves as a sexual being, as worthy of being a sexual being, a fully functional sexual being, not I will never live up to expectations, or I will never fit the norm kind of sexual being, but for who they as an individual are. You know, so as a doctor, what I say, my sex positivity, contributes hopefully to them believing that about themselves. But for you guys as psychosexual therapists, it's much more important to help that person to believe that about themselves, because I think that is one of the biggest barriers, that they don't believe that about themselves. And then, of course, those who love them and have sex with them, and those who care for them as healthcare providers, all have to have a positive and respectful approach to sexuality and sexual relationships. Sexual health requires the possibility of having pleasurable and safe experiences, free of coercion, discrimination, violence, and preconceived ideas of what sex, sexiness, desirability, desirability, and just to stand still there a bit, Lucy Fielding talks about that a lot, about how we experiences that trans people are often objectified or seen as non-desirable, but then what they believe about themselves, whether they are able to fully desire and that their desires are valid, is such an important therapeutic process that sometimes need to happen that is not necessarily there in the individual. And I should have put this in my disclosures that over the years now, I've become good friends with the most phenomenal trans and gender diverse people. And one of the most influential people in my life is Esther Benestad-Pirelli. She's just such a amazing person that I've learned a lot from. But one of the things is the amazing resilience and the trans talentedness of trans and gender diverse people, and that we as healthcare providers so often speak about them in a way that sounds as if we pity or and it's not necessary. It is a beautifully strong, resilient community. So when I'm passionate about the things that lack for the full set of sexual justice in their lives or in your lives, it is not because I think that there is any lack in your resilience and ability to experience that full set of what sexual health and sexiness and desire and desirability and performance and intimacy and eroticism entails. It is the full capacity is there. Some people, like all of us, just need some help to get there. The amount of money that I've spent on therapy is crazy. And you would think that I would be able to keep this little ship afloat without any help. But, I've realized I don't. So help is always welcome. Okay. Sorry, I'm derailing too much, but I'm just going to read that again. Sexual health requires the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, violence, and preconceived ideas of what sex, sexiness, desirability, desirability, performance, intimacy, and eroticism should look like. For sexual health to be attained and maintained, the sexual rights of trans and gender diverse people must be respected, protected, and fulfilled. And that is then when sexual justice actually happens. So if you take that definition, because I know when I read this definition, I mean, I've read it too many times, it actually doesn't say enough. But if you go and put the trans and gender diverse people actually firmly within this definition, I think it is something that we as healthcare providers should be looking at frequently, and remember that the full set of sexual health is not a nice to have for trans people. It is just as a part of their right and who they are and what they need for their full set of well-being as it is for any other patient. So if you look at what gender-affirming care is, how we at My Sexual Health see gender-affirming care, it refers to treatments including all or some of the following that support a transgender or non-binary person in their gender transition. So there might be supportive psychotherapy, supportive counseling, hormone therapy, where the doctor gets involved, various forms of surgery, aesthetic medicine specialists, speech therapy, physiotherapy, occupational therapy, image consultants, hair removal specialists, and personal trainers and biokineticists. So, not aware of any patient that has accessed every single one of those services, but they are available. And we've got people who, as you heard now, all of the speech therapists here, we've got amazing physiotherapists that actually specialize and have hours and hours and hours of training in trans and gender diverse care, who can help post-surgery or in, can just treat a trans person who has a sore back, but who's comfortable with treating a trans person. So, and we also have an occupational therapist on our team now. And then something that I never see on these lists of gender-affirming care specialists or team members is sex counseling and sex therapy. It's kind of, if your gender is taken care of, then the sex stuff must not just fit in there with gender, and it doesn't necessarily. And then we have other people that can be very helpful to our patients and clients, and that's sex coaches. So look, we are a healthcare provider can be a sexologist if they have a master's degree in sexual health, something related to sexuality. Any healthcare provider, any registered healthcare provider, everybody on this call and any other healthcare provider that you know are already sexual health providers. They might just not be very good ones or very well-informed ones, but by default, we are sexual health providers. And if you're not well-informed, you might be a really shitty one, because there's so much power that comes from the health provider. And if they're not sex positive, and if they're not the one there that opens it up for the patient to access the services, they don't. So healthcare providers are sexual health providers, but there are people who can offer sexual health services, even if they are not healthcare providers. For instance, sex coaches. They should not be calling themselves sexologists or something like that, but they might be. They might have various forms of training, and then they might be a sex coach, or body workers or sex workers. So this is outside of the scope of registered healthcare providers. Do not put your foot into things like touching patients, doing sensual massage for your trans patient, because you want to help them with their embodiment of their sexuality. Even if you are open to things like that in your private life or whatever you do, keep it clear. If you struggle to keep boundaries clear, do not venture into the sexuality part of sexual health or gender affirming care, because you have to be super, super careful with boundaries. Some therapists would, for instance, in a process where like a mindfulness kind of exercise, where you might have taken a patient first, I've got a line here now, so you might have taken them through a process of holding it in their hand and smelling it and, getting in touch with their senses. And then it might be okay to touch a person on the hand just like that in a further step of that exercise. But if you're doing that, you better make sure that you're doing it in the context of a multidisciplinary team under supervision. And I would actually advise you not to touch the patient. Find another way of instructing them to do the exercise, and do not touch a patient. Because, obviously, if you're a psychosexual provider, if you're a medical provider, we are so strict about things like, I sit behind my office with my computer when we talk about clinical stuff. And if we venture into talking about the most intimate details of a person's sex life, we are there. Well, I used to always have a lounge in my office. Now it's often online, or there's a desk now. But when I touch a person, it's very much a clinical thing. They go into another room, it is just super clinical. And then we don't talk about anything. Boundaries are important. Okay, I'll stop there. And make sure that you don't mix these boundaries. But we might, and we shouldn't exclude the amazing service that these other providers might help especially our trans and gender diverse patients with, because that they might not be able to access it through more what's the word now, a traditional kind of route, and we might get these colleagues on board. So hormone therapy, often referred to as hormone replacement therapy, we call it hormone therapy because I think it's a more inclusive term. It's not we that call it that. It is being called hormone therapy now. It seems there's a movement towards that. It refers to any hormonal intervention that we use to help a person to reach their goals. Because if you say hormone replacement therapy to a non-binary person, it doesn't sit very well with them, because they do not necessarily want to replace something. They might just want to decrease something or increase something. And it might not be for replacement. It might involve reduction of one hormone or an increase in another. Hormone therapy is a more niche term, referring to less of a blanket, one-size-fits-all approach, but alluding to an individualized approach, which is what we absolutely follow. You know, we know what drugs are available, and but we follow an absolute individualized approach. And if you start working with sexuality, then an individualized approach is, I mean, it goes without saying. So I think the challenge comes in, if you're trained, if you're working in a government clinic where there's these protocols to follow, the challenge comes in actually removing yourself from the protocol and getting into what's happening with this person, and how can you be a good provider for this person. The psychosexual providers up on here, I know you don't struggle with that much. You are trained in it, but doctors aren't that trained in it. We are trained away from it, to detach from our patients and, you know, keep a distance and not really connect. So it's something that we have a lot of learning to do there. So if we look at the principles, I mean, these are just random principles that I came up with. You know, when you do these kind of things, you tend to overthink it, and you can overcomplicate it. And I thought it's actually very, very simple. If you treating trans and gender diverse people's sexual health is in many ways exactly like treating any other person's sexual health. And with that said, I don't disregard the challenges and all the difficulties involved there, and the differentness of every single individual that a person treats. But if you now go and say that rendering sexual health services to trans and gender diverse people is completely different, it's another layer of othering for this population. So I think we just stick to the principles. Sexual health services should be rooted in sexual rights. So we've got the Sexual Rights Declaration from WAS, and this is just like an infographic to explain what they are. But again, here, if you insert the word, let's say trans and non-binary folk should be able to be treated without any discrimination. Oh, sorry, where am I now? And now my screen is covering the top part. Now I can't read what it says there on my on those first few. Oh, I didn't know you can draw on this thing actually live. Ron, can you read it? Can you read number 2 and 3? Because I now can't see it. I don't know how to take this thing away that I can actually see. Oh, there it is. There it is. Don't worry. Okay. So to live in freedom and safety. And then, of course, autonomy and integrity of body. And this becomes so important with our intersex patients, and to be free from torture and inhumane treatment, and the scrutiny that trans people until this day have to undergo in, you know, the stories that we hear from government facilities. I hope that that's now something of the past, but even with providers in private practice that really ask questions of transgender diverse people that can be seen as inhumane treatment. You wouldn't imagine asking those kind of invasive questions to any other individual just upfront like that. And then these people that you don't know are bombarded with the most ridiculous questions. It is torture, actually. And of course, free of sexual violence, privacy, not to be, their genitals do not have to speak. You know, I can't think that anybody has ever, outside of a sexual encounter in the context of a intimate relationship, asked me anything about my genitals. But we as healthcare providers feel that we have the right to ask trans people about their genitals all the time, and it's nonsense. You don't. If it's really necessary, you have to determine whether it is really necessary to speak to a trans and gender diverse person about their genitals. They have a right to privacy of their genitals and any other thing, whether they've had surgery or not, and who they have sex with and what orifice they have sex with. It has nothing to do with you in most instances, unless they want to discuss it with you. the right to the highest attainable standard of health with the possibility of pleasurable, satisfying, and safe sexual experiences. So a trans person has the right to the full set of treatments that I have to offer for sexual health services. I offer platelet-rich plasma injections, and we have we offer antidepressants, particularly for a sexual dysfunction. A trans person has the right to access that just the same as any other person. And you shouldn't, I have to remind myself also not to forget about that they are not only there for me to manipulate their hormones, but really to offer them the full set, and it's their right to have the full set of services that we offer for people to attain sexual health. And then the benefit of scientific progress. And the problem is that so much of the science is not done with the voices of trans and gender diverse people present. So, I've spent so much of my time acquiring knowledge on sexual health, but in how much of that am I really acquiring knowledge on what it is that matters for trans and gender diverse people? And that's why, like at the World Association for Sexual Health, we as an association particularly pertinently state that we are a science-based professional organization, but experience-informed, and this is particularly related to the trans and gender diverse community, because sometimes there is just no science. We just have this beautiful collective knowledge of generations and generations of trans and gender diverse people whose experiences weren't seen as science, but is there. And we as healthcare providers do need to turn to that to inform us, because the science often lacks. And not that there isn't science. I mean, there are journals dedicated to this. There's a lot of science, but still not necessarily sufficient. And then they have access to information about your sexual life. So, now I've been a gender-affirming healthcare provider for how many years? I've never read a book on trans sex, ever. I know that there is a lot out there, but why has it never crossed my path? And why didn't I feel that that's now the next thing that I should gain knowledge about, having read hundreds and hundreds and hundreds of books? It raises a question. If I haven't read that book, who has read that book in South Africa? It's a brand new book, but who has read any other books on, and I'm not talking about, if that's your thing from an erotic perspective, or if you're interested in the historic literature, and that there's a lot about that, but actually how trans people have sex and how we can help and aid that process. Healthcare providers have way too little knowledge about that. And about that, and then where on earth does the trans person get this knowledge? Luckily, the community is strong. And if they are the kind of person that's comfortable to be in the community and to learn from the community, not all people are like that, or have access to a community, then where are they getting knowledge about it? Because, I do this TV show with Minky, and it is crazy to see how little people know about cis hetero people who have penis in vagina sex that everybody talks about. All the sex that's ever spoken about is this kind of sex, and how little they know about it. How must people who don't fit that exact box know about it? And yes, there is information, but it is just not as forthcoming as it is for the rest of us. And then comprehensive sexuality education. The trans child has the right to receive comprehensive sexuality education that also pertains to them, and not only heteronormative education, and to marry whomever they want. And luckily in South Africa, this is possible, but not without challenges. And to have children or not. And also again in South Africa, yes, this is possible to the few who can afford it. And of course, freedom of speech, freedom to associate, participate in political life, and access to justice. And I'm ramble over those, but that forms the basis of what we can do. If those didn't go before us that did the fighting in these last 4 blocks, then we wouldn't have been able to be here today and speak so openly about being able to deliver gender-affirming care to our patients. So no, I don't know how I got that blue stripe on there. I'm just leaving it there. So the second principle is decision to talk about sex, relationships, genitals. To talk about sex, relationships, and genitals is not that of the trans and gender diverse person, not the healthcare provider. This has to sink in, and I am absolutely preaching to the choir here today. I know that. But if we don't shout it to the rest of healthcare professionals that supposedly offer gender-affirming care, but within 5 minutes of a person walking in there, they are inquiring about their genitalia. It's something that I've been challenging in training that we do at My Sexual Health for a long time now, because the typical sexual health curricula is developed for public health purposes. You want to know if a person has anal sex because you want to understand whether they are at risk of having HIV, not because, I mean, I'm saying you now, and hopefully it's not the case, but the way that the system is geared is towards us then being able to determine whether that person might have HIV and might infect other people, because when they do, it is a public health issue. Is it really important for the person sitting in front of them, for their agenda, that you ask them if they're having anal sex? I doubt it. You know, I've been a sexual health provider for 10 years. It's very, very seldom necessary for me to ask that question. And not that I'm uncomfortable with asking the question, but is it really necessary? So you have a tick sheet in front of you because somebody somewhere has determined that these things belong on the tick sheet because they need to add up numbers to make budgets. But that's not what we're talking about when we are doing individual care. And maybe I'm being too conceptual and political about it. But remember, when that person sits in front of you, you only talk about what they need to talk about. All healthcare providers should practice only ethical curiosity. And believe me, with the Sexology Training Club that we have, and it's beautiful, it's fantastic. I think it's amazing that random people sign up there, but I can clearly see who are curious in the way like they like porn and who have an ethical curiosity. And we train everybody. And hopefully then through the training process, like what happened with me, by being exposed to more and more and more knowledge and more truth and more people and more experiences, they do become credible, ethical sexual health providers. But this ethical curiosity is something, if you Google it, they talk about being curious about ethics. But Lucy Fielding talks about this in her book. And there's basically these 3 principles to it, that we have to dismantle our sense of entitlement of knowledge about our patients and clients. Just because you're their healthcare provider, you are not entitled to know anything about them. And it is something to put in your pipe and smoke, because as a doctor, specifically, I'm sure you as sexual providers are much more informed about. I mean, I go like this. I ask 5 questions and then I make a diagnosis and write a script. That's how I was trained. I don't have time to ask more than 5 questions. Within 5 questions, I need to know exactly what's going on. You know, so you learn to ask these most probing 5 questions. And it doesn't work like that in gender-affirming care. You are there to help the person reach their goals. So you're not entitled to any knowledge. And then you need to seek permission constantly, and consent to talk about sex, genitals, relationships can be, like any other form of consent, withdrawn at any point. And you need to keep on checking, because remember the power dynamic in that room. If you've asked a person once, would you like to discuss this with me? And they say yes, and then you continue with your power, probing them about certain things, they might become uncomfortable at some point, and just like people do in the bedroom, might not feel comfortable to then tell you, listen, there is now a point that I have crossed the discomfort barrier that I'm actually not comfortable to talk to you about any further. They don't have the assertiveness to do that, due to multiple things, one of them being abused by healthcare systems, often being abused by, you know, my location of self kind of person, imposing our ideas and values and whatever on them for maybe a decade or a few decades. So you, as the healthcare provider, should be the one sitting there and going, checking, whatever. I mean, whether you need to check verbally, or can you look at a dilation of pupils or clenching of fists, or what is it that you use? You already use it to make sure that the person is still okay, and then ask verbally if they're still okay to continue to talk about this. You know, if the short skirt, are you wearing short skirts kind of question is, if you can see that it causes a little bit of discomfort, check whether and check with yourself whether it was really necessary to ask that question. And then treat the client in front of you and not your picture of them. And this is something that doctors are absolutely, we're shocking at this, because we are taught to, as I said, from the 5 questions, make a diagnosis, write the prescription, and get that person out of there. So I quickly want to say, oh, okay, Muslim, Muslim. Oh, okay, yes, there, I've got my box. Muslim is a box. So now I'm done. You're in a box, and I know, I assume 100 things about you, but no, you have to make sure that you keep with your ethical curiosity, keep making sure that you are actually working with the person that is sitting there in front of you. If you are not going to be able to really understand where they are at and what their real concern is, how will you be able to help them to develop a solution for that, whether it is that they can't achieve an orgasm, or that they've lost their desire completely, or just that they're struggling to find a partner. You have to be right there with them without your own set of assumptions. If at all possible, get your training in a formal manner and not expect the patient to pay you to educate you. So I should have also started this talk by thanking the patients that educated me, because, when I did my first set of gender-affirming hormone therapy for a patient, I read like the standards of care. It was probably, I don't know if it was 6 at that time. I just read it like you would read any other document, more or less like I read the Bible. And I was like, oh, okay, no, but we don't have that in South Africa. No, that's too expensive. Okay, I think I'm going to try this. I didn't even know somebody who prescribed hormones to trans people, not one person inside South Africa. I knew many outside South Africa, and they knew I'm the crazy one that runs behind them at a Congress and ask probing questions until I get my answers, because I need to go back and treat these people that nobody could teach me. Then, because WPATH wasn't doing online training at that time, so when WPATH did their first online training, it was, I did it. But by that time, I had seen hundreds of trans people without any formal training, having multiple, supposed qualifications and stuff. But don't think in a master's degree, in a fellowship, in a higher diploma in HIV and sexual medicine, which is the highest qualification you can get in South Africa in sexual health, that I have one lecture on gender affirming care, not one in any of those qualifications. So yeah, we can't expect the average healthcare provider to know a lot about it. You need to go out and access your knowledge. But most of what I know about it today is what I learned from the people I spoke to, sitting in the chairs in front of my office, and they graciously undertook the emotional labor of teaching me, paying me, and teaching me in the process. And that's just amazing. And I'm grateful for that forever. But, being here tonight, you are helping them to do less than that, less of that. Then, like in all sexual health consultations, you apply the placid model when you work with trans and gender diverse folks. So the placid model says that you get permission, then you give limited information, specific suggestions, and then intensive therapy, which most people will need to refer to, because unless you are, so in like sex counseling, with us, a physio can do some sex counseling, doctors can do sex counseling, nurse therapists, speech therapists can do some sex counseling, give basic information, the limited information stuff, and you answer questions and do like a Senseifocused kind of process. But when it comes to therapy, sex therapy is for a psychotherapist. So don't put your foot into trying to help a person with their childhood trauma if you are not primarily a trained therapist. Please, I get a heaviness in my heart if I think of that, because out of the goodness of your heart, you think you're doing them a favor. And yes, we all have to be super supportive and affirming, and but the process is to get them to a really trained therapist to help them deal with the trauma or whatever is necessary. But as I said, it's a small number of people that actually need the full-on therapy. You can do almost everything in sexual health with permission from the patient, and then giving them limited information, which is general information. So now, after preparing for this talk, our consent form is already 15 pages. It's going to 20 now, because I know that there's much more about sexual health that I actually need to go and put into that consent form, which is like general information. So people can see where are the hooks. They can see that, yes, you are somebody that prescribes hormones, but I can talk to you about anything related to sex. And then this person comes and they say, for instance, you know, I hate my morning erections, but I do still want to be able to penetrate my partner as a trans woman. So then I would say for them, a specific suggestion for that person would then be, okay, we could for you maybe have your testosterone slightly higher, that it's not high enough for you to get morning erections, but if you want to attain that erection, it might happen spontaneously. We might give you a PDE5 inhibitor. You might want to purchase a pump. You might want to put an injectable in there. And, you know, so those are specific suggestions that any doctor can give a person based on their specific situation. And then when you do that, you will use the words that they want to use, because very unlikely that that person wants you to refer to that as a penis. And if you don't know what to refer to, external genitalia is a neutral term, but you know, you can't say put an injection into your external genitalia because it might mean the scrotum or the testes. So you need to have the right term there. So you just can ask, how do you refer to it? And use the terms that the person uses. It's important that you get that right. It's not that easy for me. I literally write down in my notes, this person calls it a stick, this person calls it a dick. It's an Afrikaans person, but they call it a dick. For me, I would never talk about a dick. You know, I'm like a decent girl. I don't talk in Afrikaans about a dick. It's easier to do it in English, but now I make a note on my file that this person calls it their dick. So, I mean, I'm talking about a trans guy now. So, you know, make sure that you get it right, because stick for the one person might be really insulting for the other person, for instance. I know you guys know this, but just as a reminder. And then once it's now, or for instance, then if you've given the suggestions, but they're not the person who can prescribe the Viagra, if that's what they choose, you refer for that. Or if it is like, hell no, you know, that's actually not what I meant. Please, I don't want to need to touch there. I just want to keep my partner happy, because my partner makes me feel like less equal in this relationship because I can't satisfy them sexually. Oh, okay, that's actually what it's about. So could we explore other ways of making your partner feel sexually satisfied? So I'm perfectly comfortable to have that conversation, but if you're not, that would be something that you refer to somebody that is a psychosexual therapist that can actually have that conversation properly, because this is a real struggle for trans people that I've come across in my practice, that I mean, all of us all the time feel, am I really good enough for my partner? Am I living up to expectations? Am I, you know, you are benchmarking yourself all the time. So of course it's also a problem for trans and gender diverse people, except if like there's massive discourse in my kind of body cis het life, where if you know, my husband thinks I'm too fat to have sex with, I've got a lot to say to him, because he's like literally politically incorrect to think like that. Whereas for a trans person, do they have that agency, that assertiveness to go and tell their partner to go F themselves if they don't want to be with them or something like that, you know? And it is just like with any other client, being there, seeing what it really is that's going on, and is there maybe a way of resolving that might actually have nothing to do with genitalia again, or something like that. Okay. So contrary to what we were taught, the location of self can be very effective in therapy specifically to identify the intersectionality. So look, and now I've just put this location of self of mine here again, and I am the kind of doctor that I am very honest, just as a person. For those of you who know me, I'm just like by nature, I'm honest. So the location of self thing comes naturally to me. I don't try and hide any aspect of who I am, and I will just naturally frequently refer to something of myself. But please don't do this. I mean, you can't sit there and every time a person, any kind of patient or client says something, then you say, you know, for me, it's like this and that. It doesn't go down well because the people are there to talk about themselves. But sometimes some self-disclosure is actually valuable. And sometimes, especially the greater the gap, the more valuable it becomes to say, you know, so this is where I am, and that is these are mine, what are yours, and then so what is the intersectionality there between us, and how can we bridge that, because that bridging needs to happen for that person on a daily basis in so many different relationships and contexts. And if you could maybe in a therapeutic context help them to navigate that kind of thing. And I know I'm now venturing into therapy that is really not my field. Maybe at another stage, one of your experienced therapists can talk more about how this could be done effectively. But I don't think I don't think it's advisable to try and offer, especially if you're going beyond prescriptions for hormones, to offer a full set of gender-affirming care to a person without you being a real person there and being there to connect ethically, keeping the transference and the counter-transference and everything in check. Not that I ever came across the terms transference and countertransference before I had already, only when I was doing my master's degree. It's not something that doctors really get trained in, just so you know, in case some of you, I'm sure that the psychotherapists out there are aware of how poorly doctors are trained in that and how they often struggle with those kind of boundaries. Sensate-focused therapy is a great therapeutic tool for patients in general. So if you don't know how to do sensate-focused therapy, I would love to attend a lecture by a trans or gender diverse therapist who knows a bit about sensate, or a lot about sensate-focused therapy, to teach us how can we custom-make it, how can we custom-make the language, how can we make sure that we get the nuances right of teaching sensate focus to a trans and gender diverse person. If you go onto YouTube and you put in there Dr. Elna Rudolph sensate focus, you'll see a 10 or 15-minute video of how I explain, and I try to be gender neutral, I hope, in it. But obviously you can use much better language, because what you do in sensate focus is you take the focus completely away from the performance. So what each body part can do and how the body responds to stimulation. And that is not what is important, but actually being in the body, the mindful experience, and then the whole process of accepting the pleasure that this body can have, although it's not maybe the full picture. And we do this for all people with some form of sexual dysfunction, and just getting in touch with the fullness that there already is in their sexuality. Yes, there might be gaps, but so there is for all of us. So where can you start to find those positive places to go to? And there are lots of therapeutic techniques that you can follow, but if you want a simple one, sensate focus, and a person can do sensate focus with themselves initially and then later with a partner. And then it should be absolutely individualized. And I had quite a few case studies here about, for instance, getting the erections, or you see non-binary people that might want to be able to, sorry, I see now there's a bit of a background noise. So for instance, I remember the first non-binary person I saw wanted big sensitive nipples, but not breast tissue. You know, and I was like, I felt so uncomfortable with that, because I didn't understand what a non-binary person was. I came to terms with trans, and you know, then okay, now we're going over to that binary, and they're uncomfortable. But this in the middleness was very difficult for me for a long time. Now I love it, because I love hormones, and often, well, my little role that I play for a non-binary person is getting them to that hormonal balance that makes them feel comfortable. So you now I've done a lot of this kind of thing where we play with the hormones to see what is it that we can do for you? And then in terms of sexual health, for instance, reaching the orgasm, or maybe still being able to ejaculate and so forth, we might need to tweak those hormone levels or use other things, like something like bupropion makes ejaculation easier. So you might add bupropion for a trans woman if that is still an important part of what they wanted to experience. And then, you know, the switch process of care is like I could do a whole hour on that, but I think it's very applicable. And if I can just simplify it for how you would do it for trans and gender diverse people, you would go, are you sexually active with yourself or other people? Just as a standard question in every well, not every, because that person might come in there with a completely different agenda, and then please don't throw this question in there. But let's say now it's me, my patient's coming for their annual checkup. With most of them, I know them very well already, so I'll ask them, are you still with Peter? But, you know, if I didn't know, I would ask, are you sexually active with yourself or any other person? It feels a bit awkward to me to ask it like that, and not actually person, I must say people, because it might be more than one person. But today I saw a non-binary person that wants to go on to masculinizing hormones, and they spoke about their partner in the first hour consultation. And I deliberately never asked of the gender of the partner because it was completely inconsequential. And then today they asked about the T getting onto the partner. So I asked whether the partner was assigned male or female at birth. And then they said that they have one of each. So okay, cool, you know, but it has taken me 10 years to be straight face about that. And then just like without missing a beat saying, okay, so for the assigned female at birth partner, if they're not themselves on masculinizing hormones, then, you know, it's more of a risk for them than for the other person. So for that person, I asked them in the first consultation, are you sexually active? I would usually just ask are you sexually active, and then inquire a bit more if they say no. I would probably then say, so also not with yourself then. And then, but the follow-up question is this by choice? So not all people have to be sexually active. Of course, there's nothing wrong with you necessarily if you're not sexually active, but just check it. And if it feels awkward to you, can you imagine how awkward it feels to that patient to tell you, listen, I'm not sexually active and I'd love to be. So is it by choice? Yes, it's by choice. Okay, cool. And then if they say, yes, it's by choice, then you can always still say, you know that you can always welcome to raise any sexual problems with me at any time or something like that. Just give the patient permission to talk to you about it. Let them know that you're that kind of therapist or doctor. And then or even speech. Well, no. I'm so used to we're training the physiotherapists to be and like Karen has had lots of training in what would be appropriate. I wouldn't think that it's appropriate for a speech therapist to ask a person if they're sexually active. I don't think it is necessary for you to go there. That would be curiosity. But if the person spoke about something related to their sexuality, which they do, because you as speech therapists end up being these people's, you know how they struggle with their boundaries with you guys. I've heard the stories, and you know they become they love you. They so value you as a person in their lives that they will often probably share things that you might feel incompetent, because if a doctor didn't have proper training in talking to people about sex, I'm sure the speech therapy curriculum on that was rather scanty. So yeah, I wouldn't probe that question as a speech therapist, but if they did, then you could go over to the next question. So let's have a special lecture for the speech therapist on that. So back to this. Are you sexually active? No. Is it by choice? Yes. Okay, nothing else to be said. No. If they say no, it's not by choice, then say, how can I help? Is there something you want to discuss with me? Something along those lines. So you open it up to them. You have the power there, but you be then that person with the power and opening it up, and they might start talking or not. And then if they say yes, are you experiencing any sexual, are you sexually active? Yes. And then, are you experiencing any sexual problems that you might want to discuss with me? So you don't have to go and ask them about every single thing of their sex lives. Just put it open. And then they might say, yeah, but I don't want to discuss it now. Cool. Then you just say, we'll do it at another time. Let me know if you want to. Or like what I would say is, have you seen on our website, we've got like a list of people that are very comfortable to talk about that. If you don't want to, maybe you want to go and look up some of them, maybe want to talk to them or something like that. So you just sex positive and affirm the fact that it's normal to have sexual health needs, and that you as a therapist or as a doctor or whatever you are in that person's life are comfortable to talk about it. And then work in a multidisciplinary team. Do not try and do this by yourself. Really, it's not in your interest. It's not in the patient's interest. Work with a team. It is delicious to work with a team. And then use the correct terms. You see, this is how, while you guys were talking, I remembered that I didn't actually put it in there, but I think I've referred to them. So even like, you know now, I mean, we don't say breast reduction to trans men, we'll say top surgery. So, and even screening tests, they don't like it if you say you need a pap smear, you know, so you might just say, I need to do your bottom screening or something like that. Make sure that whenever you can, you do not have to refer to a term that might cause discomfort for them. And then patients are not always honest, and that is actually also okay. Sometimes you know that they lie about something and you're not there to police them. I raised this today because today I saw a person that's a professional, a trans female, and they came, I saw them previously and they came with their bloods, and then the bloods looked like they were actually on hormones already. I could see that it looked like they were on hormones, and I asked them probably in 10 different ways if they are not already on hormones. And I mean, they just signed the consent form that they said they read 3 times that said that, please, if you take anything else, please just always let us know. That we need to know. We don't advise you to take anything other than what we prescribe. And then now I phoned the lab. I let the lab rerun the 1,000 Rand test. I mean, it's crazy because this person's test is completely wrong. And what's going on here? I thought they had the pituitary adenoma. I spend half an hour extra here because there's something seriously going on, not just to get an email to say that, no, they are actually already on hormones. And I don't understand what about me makes them not want to tell me, or why was it so difficult that they didn't want to tell me. But it just made me realize again that they don't always tell us the truth. And I mean, I think it's actually okay. They can share with us what they want, but they obviously, their process is influenced by them not telling us the truth. But that's also a form of like a very patronizing kind of thing to probe for the truth. They share with you what they feel is necessary. So luckily they did share, and now we just keep them on that dose of hormones that they are on. And then a lifelong student, so I have to put a little plug for the Sexology Training Club and the training that we offer through My Sexual Health. And I would love for every single person on this call to be a part of the My Sexual Health team, because you know, the more we as healthcare providers with a keen interest like you guys can learn from each other, the better. And the more we can inform the public that we are credible sexual health providers that work in a team, we work under supervision, we do a certain amount of CPDs every year, we take it so serious to be the best healthcare providers that we can for our patients. Do we mess up? Every day, you know, definitely. I mean, just the fact that we try doesn't mean that we're great at it, but at least we try our best to be credible sexual health providers. So my take-home message that I thought was, and this is straight from Lucy Fielding's book, she explained to this patient that really struggled to find themselves sexually as a trans or non-binary person. She explained it like this. She said, now I just want to see how far we have to close now. Okay, sorry. I took so long, but I want to share this with you because I've already used this now with cis and trans patients since I've read this. So how do you build a puzzle? You know, you get the box with the picture on it, and then you throw out all the pieces, and then you go and look for the corners, and then you look for the edges, and you put that together, and you look at the picture on the box, and then you put all the orange pieces together and the blue pieces together, what you think might fit together, and then you form this picture based on what you see on the box. But for trans and gender diverse people, the box is broken and gone, like many of my kids' puzzles. And there are pieces missing. Finish and claw, there are pieces missing. But then the exercise that she then explains is like, having a puzzle in front of her and asking the person, is there maybe one of these pieces that you like something about? Maybe a color, you know, maybe a pattern. Is there one piece that you like? Okay, so pick that piece up and have a look at it and a feel of it, and then put it in your pocket and have that piece. You keep that piece, it's your piece. And then at some point, maybe take another look at the pieces and see if there's maybe another piece that you like. And if there is, put that one also in your pocket. And then after a while, you could see if you could maybe make something pretty by putting those things together, and maybe even something meaningful, and maybe even something much more wonderful and elaborate than the grid that was on the original box. So it does not have to fit in a square, and it does not mean that it needs to be only puzzle pieces that makes that picture beautiful. You could put other things in there. So this is now in the therapeutic process for a trans person. And I mean, just even having that conversation with a person as a doctor or even as a speech therapist, you know, just saying, you know, is there maybe one piece about your sexuality that you can really truly own, and own that? And are they 10 and are they 30? Fantastic, because for many they are 30 already, but there are 7 that they hate, that they can just throw away, just throw it away. But and it's fine, and it might be okay without that 7, or you might find 200 additional pieces that you can add into the most amazing picture in the end. And that's the capacity that sits within our trans and gender diverse patients in terms of their sexuality. And if we as healthcare providers don't view them like that, who will? So then they end up in the realm of where it is only being fetishized and filled with curiosity and shame and blame and all kinds of other negative emotions. So that is what I would like to encourage. Then I had some case studies written down here, but now I will conclude. There's my contact details. If you wanted to get in touch with me, you're more than welcome. I'll give you my cell phone number as well. Please do not give it to patients, but I'm very, very happy to always interact with any healthcare provider. Now I do clinical work only on Tuesdays and once a month on a weekend. So I have much more capacity to engage with colleagues. Okay, there we go. Thanks, Ron.
Thank you so much, Elna. Sure. Firstly, I want to thank you for, your honesty and your self-reflectiveness in the way that you presented. I think that needs to be recognized and needs to be acknowledged. You've taken us on a tour de force journey over this time.